Good afternoon, everybody. I'm absolutely delighted to welcome you to this FLAIR and static trial update webinar that we are hosting at CLL Support. I'd like to welcome all of you as participants. I'd also very much like to welcome our speakers. I'm Hilary Lindsay, I'm the chair of CLL Support, and I'm also on the trial management group for the static trial. We've got some fantastic speakers here this afternoon. We've got Dr. Tal Munir, who's a consultant clinical hematologist at the University of Leeds, where he is also the principal investigator of the FLAIR and static trials. We've got Professor David Allsup, who's a senior lecturer in hematology at the Hull and East Yorkshire hospitals, and he's on the trial management groups for both the FLAIR and the static trials. We've got Lelia Dooley, who's a patient representative on both the FLAIR and static trials and on both trial management groups. And we've got Rhiannon Lamkin, who's the senior clinical trial manager at the University of Leeds. And she very much, as her title says, looks after the static trial. And we're going to hear from each of them in turn. And then there's going to be a question and answer session, and then there's going to be a discussion. So as we go right through the call, if you'd like to put any questions you've got in the Q&A box, that would be fantastic. And I'd like to emphasize that those speaking don't know anyone's medical history, and so they can only be able to answer questions in general terms. I just want to say thank you very much to AbbVie, AstraZeneca and BeiGene, 3 pharmaceutical companies that give us grants each year to cover our educational activities. As the slide says, they have nothing to do with the content of what we're talking about, but we do get support from them and want to acknowledge that.
Thank you very much, Hilary. What we're going to do is we're going to have a brief recap about the treatment of chronic lymphocytic leukemia, a little bit about where we've come from and the treatments in the past, and then we're going to talk about where we're going in terms of trials and new treatments and really trying to improve outcomes for people that need treatment for this condition. And so what we'll cover is clinical trials and progress within the treatment of chronic lymphocytic leukemia. And more specifically, we'll talk about the trial called FLAIR, which ran for many years from sort of around 2013, 2014, and then finished recruitment a year or 2 ago. And we're going to share some updates from this trial with you. And then we're going to talk about an ongoing trial called Static that is currently open to recruitment around the country. And then really where we're trying to go in general with treatment for chronic lymphocytic leukemia. The next slide, please. And so the first 2 speakers is myself. I'm David Allsup. I'm a professor of haematology at the Hull York Medical School, but mainly based within Hull. And my clinical practice is in the Queen's Centre at Castle Hill Hospital. And also Dr. Munir, who I think he can introduce himself.
Hi everyone, thanks David. I'm Tal Munir, I'm a haematology consultant. I work at St James's Hospital in Leeds. I'm leading the FLAIR and static trial at this moment in time, and as all of these trials are being run from University of Leeds, I deal with the team and run the trial with the help of my fantastic team at University of Leeds.
Thanks, Tal. So we go to the next slide, please. So as I'm sure a lot of people listening to this talk will be aware, chronic lymphocytic leukemia is a relatively common blood cancer. And in 4/5 of people, it's picked up incidentally. So that means when people go and have a blood test for a checkup or for another reason, the test is found to be abnormal, and then further investigations reveal this condition, chronic lymphocytic leukemia. And most people, a lot of people, have no symptoms related to this condition when they first present. And a proportion of people never require treatment. It just sort of sits there and bides its time and never really changes. But for other people, over a period often of years, the disease can change. and often Dr. Munir or myself will notice the change on the blood test. That's often more leukemia cells appearing in the blood, or the development of other problems such as low red cells, which is called anemia, or low platelets. And other times people will start to feel less well. People can have problems with worsening low energy that interferes with their lives. They can lose weight or develop lumps related to swollen lymph glands. And if the disease is making people unwell, then treatment is required. And there's a long history of various treatment approaches for this condition. So the slide we've got here really is a timeline dating back sort of over 60 years to the first effective treatments, and then going right the way forward to more or less where we are now. And looking at the far left of this slide, in the 60s and 70s, the main aim of treatment was really just to make people feel less unwell if they had symptoms related to this condition. And the initial therapies were usually given as tablet form, and the tablets that we used was one called chlorambucil or cyclophosphamide. And chlorambucil was first discovered really in the mid to late 50s. And these are given as tablets either every day or for a few days every month, and they would often be successful at shrinking down swollen lymph glands or improving the blood counts. But often the responses to these treatments were short-lived, and once the disease became active again, it would often fail to respond to subsequent treatment with these agents. And then as time goes forward into sort of the early mid-80s, other chemotherapy approaches were found, and these targeted different weaknesses in the cancer cells. And this group of agents are called nucleoside analogues or purine analogues. And the most commonly used for the treatment of CLL is a tablet called fludarabine. And this is given either on its own or in combination with other drugs, again for several days every month. There are other similar agents that are given by infusion called pentostatin or cladribine. These agents improved the response rates, so they made it more likely that your lymph glands would shrink down or you'd feel better at the end of it. And those responses would often be maintained for longer than with the older treatments. But ultimately still the disease would come back. And then in clinical trials that were done in the 90s comparing fludarabine with chlorambucil, it was found fludarabine was more effective at inducing remissions, but didn't do the most important thing that we all want, which is to make people ultimately live longer. And these newer treatments, fludarabine, though effective, tended to have more side effects in the way of low blood counts and causing infections, some of which could be difficult to treat. So going forward, scientists found that if you take fludarabine and combine it with other drugs, particularly cyclophosphamide, the chemo drug that's been around, that you could develop a more active combination. So the combination of fludarabine and cyclophosphamide together would induce more remissions, so make more people feel better and control the disease in more people and keep the disease quiet for longer. But again, it didn't ultimately convincingly make people live longer. When the disease came back, it was often still difficult to control. There was then a further stepwise addition. So there was a discovery of a group of drugs called monoclonal antibodies. And effectively, these are engineered forms of antibodies. So everyone's got antibodies in the blood, and antibodies are things that when you have an infection, a bug gets into your blood or your body, the body makes antibodies which stick to the bug and help get rid of it. And scientists have found a way to make these antibodies in a laboratory, and you can make them stick to whatever you like. And so it was found that if you make an antibody that sticks to a cancer cell like leukemia, you can then use that as a form of treatment. And the first of these that was widely developed was a drug called rituximab, which is given as an infusion. It was then found, I don't know, maybe sort of 10, 15 years ago, about 15 years ago, that combining fludarabine and the drug cyclophosphamide with the infusion rituximab was again much more effective. And the remission, more people had remissions, the remissions lasted for longer, and that this treatment did make people live longer than prior therapies. And a proportion of people that are treated with this combination, which we call FCR, have remissions so durable that they never relapse. The prevailing wisdom, or wisdom is not the right word, the prevailing idea in CLL is that it can't ultimately be treated. But some people who are treated with FCR seem to have a remission so profound and prolonged that it's almost equates to a cure. So FCR was then viewed as a gold standard treatment, which is a term that's often used by clinicians when they sort of strike upon a new therapy that supersedes all that came before it. And FCR is effective, but again, not without its problems. It can cause low blood counts, it can significantly increase the risk of infections, and can make people feel quite unwell on the treatment. Additionally, people who have other health problems, particularly health problems relating to the kidneys, could find FCR treatment very strong, and it can be difficult to give to certain people. So there's still plenty of scope to improve therapies. Again, so moving forward, drug companies found that if they improved on the rituximab to make it stick to cancer cells better, that they then made an antibody called obinutuzumab, which again is an antibody that sticks to cancer cells and was found to be more effective than rituximab. Scientists learned more about chronic lymphocytic leukemia, and particularly they learned how the cancer survives and what the weaknesses inside the cancer cells are. And once these weaknesses have been found, treatments were made that specifically targeted them. So an example of this is a tablet called venetoclax and another tablet called ibrutinib, and these target different weaknesses. And generally these tablets are given continuously. A whole variety of clinical trials showed that venetoclax and ibrutinib were far superior to the historical treatments I've just described, and really over the past 5-10 years have largely supplanted the use of chemotherapy. Scientists have worked to improve these tablets to make them even more active against the cancer. And so ibrutinib has been developed, and a new tablet called acalabrutinib has been made, and another tablet called zanubrutinib, which all work on the same principle but successively become more potent and with probably lower side effects. And now scientists are sort of combining these newer treatments like ibrutinib and venetoclax together, or acalabrutinib and obinutuzumab, the infusion, to really induce deeper and more profound responses. But we're still continuously trying to improve things. We're trying to improve treatments, and most of all, we're all aiming to cure CLL, and we're also aiming to treat it without actually causing new problems in the way of side effects. Can the next slide, please? So this slide sort of summarizes some of the commonly used medications at the moment. So on the left, what you see something called covalent BTKI, and that basically is referring to ibrutinib, or acalabrutinib or zanubrutinib, which are these commonly used tablet therapies that are given every day. And they target something inside the cancer cell called Bruton's tyrosine kinase. And essentially it's like a light switch. These tablets like ibrutinib or acalabrutinib, they turn BTK off, they turn the light switch off, so the power goes off and the cell sort of stops living. Venetoclax is another tablet that's commonly used, and that targets a weakness in the cells called BCL2. And BCL2 basically tells the cell to stay alive. So the BCL2 gives messages to the cells saying stay alive, stay alive, stay alive, and the venetoclax again switches that off, and the cell's no longer told to stay alive, and it dies. And on the right, there's a cartoon showing a drug called obinutuzumab, which is this monoclonal antibody. So it's an engineered protein that sticks to the outside of the cancer cells and is given by infusion. And that does several things. So when it sticks to the cancer cell, it gives the cell a message saying kill yourself. The other thing it does is when it sticks to the surface of a cell, it can draw in other healthy immune cells to help kill the cell. And it can also cause proteins called complement proteins that come and stick to the cell and then punch a hole in the cell and kill it. And because these three treatments work in different ways, so the scientists have thought that, well, if you combine them together, then you come in at you're attacking the cancer cell from multiple different angles. The next slide, please. So this shows, as I've tried to describe, the treatments for CLL have gone from sort of tablet chemotherapy that is largely partially effective up to highly effective targeted treatments. And this graph is showing that over time, going from left to right, that the outcome, the survival of people with chronic lymphocytic leukemia is progressively increasing upwards. And by some estimations, people treated in clinical trials, the outcomes now are close to those people who don't have chronic lymphocytic leukemia. The treatments are so good. The next slide, please. So that leads to the clinical trial FLAIR. And FLAIR was designed by Professor Hillman more than 10 years ago now. And FLAIR was designed when the chemotherapy FCR, or fludarabine, cyclophosphamide, rituximab, was the mainstay of treatment. And around this point, the new tablet ibrutinib had been approved. And so the thought was, well, maybe this tablet treatment that's given every day that is easier to give and seems to have fewer side effects, maybe this is as good as FCR in controlling the leukemia. And initially, the trial was designed to give the ibrutinib in combination with rituximab, which is this infusion that sensitizes the leukemia cells. And so the first part of the trial was comparing FCR chemo with ibrutinib rituximab. After time, it became clear that the addition of the rituximab wasn't really contributing much, and so that was stopped. And the trial carried on comparing the FCR to the ibrutinib on its own. And again, around this point, other clinical trials showed that you could combine ibrutinib and venetoclax together. And this trial was done by the Leeds unit under the leadership of Professor Hillman and Dr. Munir. And there's a trial showing that these two drugs could be safely combined. And so FLAIR was changed to have essentially three elements. So some people got FCR, which is the established chemo that we know works. Some people got ibrutinib on its own, and some people got ibrutinib and venetoclax together. And this trial has completed, and some of the results are now coming out. The ibrutinib and rituximab an FCR comparison has shown that ibrutinib and rituximab is safe and effective, and is more effective at keeping people in remission and inducing remissions than the FCR, with fewer side effects. The other comparisons, so the comparison of ibrutinib, venetoclax, and FCR. It's been shown that ibrutinib and venetoclax is a more effective therapy. You get more remissions. The remissions are maintained for longer, and it seems like people live for longer with the ibrutinib and venetoclax. The next slide, please. So the trial was designed in a very clever way. So rather than doing what most clinical trials do, so most clinical trials will compare a year of a tablet versus a year of another tablet, or 6 months of one treatment versus 6 months of another treatment. You just get a defined period and then you stop. However, everybody's different, and every case of CLL is different. And what the team in Leeds are trying to do is actually hopefully cure leukemia in some people. So what the idea was is that you would have the ibrutinib venetoclax, which is a very, very effective treatment, and you would carry on with it until you'd had a remission. So everything is better. Any swollen lymph glands have come down. You've cleared the leukemia cells out of the blood when you sort of look down the microscope. But it's known that there can still be leukemia cells lurking at low levels. So the laboratory team in Leeds would measure people's blood, measure people's leukemia level using very, very sensitive tests. And so the ibrutinib venetoclax was continued. It's continued until a remission was attained, which means that people feel better and everyone's better. And then you go on a bit longer until you can't detect any leukemia cells via very, very sensitive tests. And then you go on a bit longer after that on the assumption that the tests aren't perfect and there might still be a few leukemia cells lurking somewhere. And then after a defined period of time, you stop. And so the idea is that you're giving a duration of ibrutinib venetoclax, and the duration is guided by a person's response and using sensitive tests. And the term that's used is MRD-directed therapy, which is just a way of saying that the duration of the treatment is guided by sensitive lab tests. And this is unique in the world. It's a highly innovative approach. Go to the next slide, please. So that the trial is completed and results are coming out, and the summary of the results is here. So the tablet ibrutinib and venetoclax, ibrutinib and rituximab is better than FCR chemotherapy in terms of keeping people in remission. Using ibrutinib and venetoclax in this sort of monitored approach is superior to chemotherapy by all meaningful measures. And then further results are pending. So is the ibrutinib and venetoclax better than ibrutinib? And then other sort of final results of various analyses are ongoing. But the results are really exciting, and they were so exciting that they were published in an international American journal, and it's been very, very widely received and recognised. And Dr. Munir and Professor Hillman have presented this in front of thousands of people in various conferences around the world. So really try and get this approach taken forward by other people in other countries. So I think the next slide, please. So in terms of where are we right now in the UK? So if Dr. Munir or myself meet somebody with chronic lymphocytic leukemia that needs treatment, what are we likely to be talking about? Well, the first thing is everybody's different, and we'd be sort of finding out what's important to the person concerned, what's their preferences and values, what's important to them. Finding out what are the health problems they have is important, as that can sometimes determine therapy. But we're likely to be talking about a treatment with the tablet called venetoclax in combination with an infusion called obinutuzumab, which is given for about a year, just over a year. And this is a very effective therapy, and the vast majority of people are in remission when it's stopped, and that remission is often maintained for many years. Within the NHS, we're allowed to give the combination of ibrutinib and venetoclax, but only for 15 months. And the reason for that is that's how the previous clinical trials of this combination have been done, and that's how the drug companies have sought approval for this regimen. But even for 15 months is a very effective therapy. The overwhelming majority of people are in remission when the treatment finishes, and those remissions are maintained for many years. And then there are other tablet-based treatments. There's ibrutinib, zanubrutinib, and acalabrutinib, which are given as a daily treatment, and that treatment's continued for as long as the leukemia remains quiet, or until such time as somebody has a side effect that means we have to stop the therapy. The next slide, please. So in terms of the sort of innovative approach that the FLAIR trial has found using the combination of ibrutinib and venetoclax with the sensitive blood tests. So currently that is not routinely available on the NHS and also in most healthcare systems in the West. And the reason for this is that this treatment is not currently licensed or approved by the drug companies. However, we're trying to sort of advocate for this with the NHS to try and show that using an individualised and personalised approach to ibrutinib and venetoclax with sensitive blood test monitoring is the right way forward. The next slide, please. And in terms of how we're trying to move this forward, so we're still collecting and reporting the data from the trial. We're trying to show that the treatments that are in the trial, they're not just making the numbers on our blood tests, on our blood reports better, that they're actually improving how people feel, they're actually improving people's quality of life, and that's something that's being looked at the moment. We're trying to see, do the various approaches in the FLAIR trial represent value for money for healthcare providers, and we're discussing it with the NHS bodies that oversee and decide on the various treatments within the UK. The next slide, please. And obviously your support is vital, but I think it's predominantly down to Dr. Munir, myself, and people like us to sort this out. The next slide, please. So that leads on to the static trial that Dr. Munir can talk to us about.